Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, my name is François Clément Bidard. I'm a medical oncologist working at Institut Curie and in Université de Versailles in Paris, France. Welcome to this program titled Monitoring ESR1 ctDNA during first-line treatment of HR-positive metastatic breast cancer, a new approach. Joining me today is my colleague, Dr. Nicolas Fusco, Director of the Division of Pathology at the European Institute of Oncology and Associate Professor of Pathology at the University of Milano, Italy. Welcome, Nicolas, and thank you for joining me in this discussion.
Thank you, Francois. It's a pleasure to be here discussing with you these extremely important topics on ESR1 monitoring through liquid biopsy in hormone receptor positive metastatic breast cancer.
So in this program, we will discuss first the biology of ESR1 mutation, and just to remind that these mutations are key driver of endocrine resistance in HR-positive advanced breast cancer. Then we'll go through the rationale for monitoring ESR1 mutation during first-line treatment and how to implement then in real life, in real practice, ctDNA-based ESR1 mutation monitoring and how to overcome the challenges in clinical implementation. And we'll discuss lastly the potential impact for patients and for the clinical practice. So let's start with our first topic, which is the biology of ESR1 mutation and endocrine resistance. I just want to remind the audience that ESR1 mutations are very important mechanisms of acquired endocrine resistance in hormone receptor positive metastatic breast cancer. These mutations emerge under the selective pressure of aromatase inhibitor therapy, and they contribute to treatment resistance. And oncologists must be aware of the prevalence and on the prognostic impact of ESR1 mutation in order to optimize the treatment strategy. So having said that, Nicolas, I have a question for you, which is, from your perspective, from a pathologist perspective, what would you consider as a key component oncologists should know about ESR1 mutations?
Thank you, Francois. So from a pathology perspective, one key concept to understand is that ESR1 mutations are extremely heterogeneous, and this heterogeneity can be both between patients and within the same patient over time. So we see interpatient heterogeneity if we test the patient seriously, meaning that the spectrum of prevalence of ESR1 mutation can vary widely across individuals with hormone receptor positive metastatic breast cancer. But in my opinion, perhaps even more critical is the interpatient heterogeneity. So in interpatient heterogeneity, so different tumor clones may harbor different mutations, and this can evolve over time. So there's a dynamic nature of ESR1 that creates true challenges for traditional tissue-based testing. So that's why the liquid biopsy approach has a strong rationale here. A single biopsy of the metastatic tissue cannot capture the full spectrum of mutation and mutational landscape. And that's why the liquid biopsy is playing an increasingly important role.
Okay, thank you. So I think that's, let's say, also from a biology standpoint, it's very important when we speak about resistance mechanism to distinguish a bit of two main mechanisms of resistance. So we have mechanisms of adaptive resistance, so which means these mechanisms of resistance are often occur early on and are often reversible. And we also have like acquired resistance, so later resistance, And this resistance also must be developed over time and is often irreversible. And oncologists must remind that ESR1 mutation remain a key mechanism of acquired resistance. So the appearing later on during the treatment, and it makes the early detection of this mechanism of resistance very crucial to optimize the treatment. So once after having reminded the biology of ESR1, now we would like to explore the rationale of monitoring ESR1 mutation emergence using ctDNA in first line in patients receiving first line treatment for their HR-positive metastatic breast cancer. So at the moment, with the current drug, we have a kind of very classical approach, which is to test for ESR1 mutation after progression on first-line therapy. So which means we are testing patient once to know whether ESR1 mutation could be detected once the disease has progressed and has resisted to the first-line treatment. But what we know is that ESR1 mutation could appear and will appear before disease progression. And we know that they will accumulate over time and eventually leading to the tumor progression. So what we could do is to move the monitoring from the late time, so when the disease has progressed, to an early setting. So which means to monitor for ESR1 mutation during the first line treatment. So which means doing a first test and then doing like repeated testing at an interval that remains to be discussed. But clearly the idea is if we want to act early on this mutation and to prevent the tumor resistance, we have to detect this mutation early on, so and before the disease progression. And so this approach, which is modifying our practice, will allow for the early detection of a resistance mechanism, but before clinical progression. And it's also opening a window of opportunity to modify the treatment before the resistance is fully established and has led to tumor growth. And this will allow to preserve the endocrine sensitivity. So which means to act on a subclone as soon as it appears, but before it has led to the actual disease progression. So this is a clinical standpoint, but Nicolas, again, from your pathologist perspective, what could you say about, what could be the importance of early testing for ESR1 mutation monitoring?
That's a great point, Francois. From a pathology perspective and from a molecular pathology perspective, I believe that early testing for ESR1 mutation is essential to establish a clear baseline before initiating treatment. Knowing that a patient is ESR1 mutation negative at the outset would provide the reference point we need to perform serial monitoring during first-line therapy. And this allows us not only to detect the emergence of mutation as soon as they occur, but and they occur often before radiologic or clinical progression, but also to observe their dynamics over time, whether they are increasing, stable, disappearing, accumulating with additional mutation in ESR1, but in different genomic position. So this temporal insight is incredibly valuable, in my opinion, for the tumor board, multidisciplinary tumor board, because it helps guide timely treatment decisions, especially in scenarios where switching therapy could improve outcomes or delay resistance. So from a diagnostic point of view, another important element is the analytical consistency. And this is a crucial point. By anchoring the testing process early and following standardized protocols through the disease course, we ensure that the molecular information that we provide remains robust, reproducible, and most importantly, clinically actionable. And Francois, now we have the rationale for monitoring ESR1 mutation emergence during first-line treatment setting from a mechanism of action perspective. We discussed this just in the previous minutes. And such a selective pressure of aromatase inhibitor leading to a ligand-independent activation of estrogen receptor is an extremely fascinating mechanism, and that provides the rationale also for molecular pathologists as to provide the testing. But what clinical data support this approach?
Yes, so let's say the concept of intercepting ESR1 mutations, so detecting them and acting on them before the tumor growth and the tumor progression, was first initiated in and explored in Padawan, which was an academic trial run in France, and which was kind of a proof of concept about the feasibility of intercepting ESR1 mutation. And in Padawan, patient could be switched to fulvestrant, which is an old third. And so we got interesting results on Padawan, and these results have paved the way for SERENA-6, which is now the most contemporary trial that we have, which is supporting the monitoring of ESR1 mutation during the first line. So what we have done in SERENA-6 is not only to confirm the finding of Padawan, so we can monitor the ESR1 mutation, we can intercept them, but we could also show a clinical benefit for the patients in terms of time to progression and quality of life. So this is really justifying now the implementation of ESR1 testing in first line to act proactively and not to react to the appearance of ESR1 mutation. So, but coming back to the ctDNA testing, it's more on your side, Nicola. It's what could you tell us about ctDNA testing, and what are the, let's say, the key technical considerations that medical oncologists should know about ESR1 testing in first line?
Yes, absolutely, Francois. This is an extremely important point because the consistency of ctDNA testing, also from a technical point of view, is essential. And ctDNA testing is particularly well suited for monitoring ESR1 mutation. So ESR1 is the ideal biomarker for continuous monitoring through ctDNA testing, particularly first-line setting, because it offers a combination of critical advantages, both from the clinical point of view, but also from the testing methodological point of view. First and foremost, it's non-invasive and allow for serial testing without the burden of repeated tissue biopsies when the tissue is available or the anatomical site is accessible. And this makes it an ideal for real-time monitoring and enable us to track the emergence of dynamics of ESR1 mutation even before the clinical progression. And that's the paradigm shift, because ctDNA also reflects the spatial heterogeneity of the disease and can capture mutation from multiple metastatic sites that a single biopsy might miss. Now, when we move into the technical consideration, we should pay attention of the different healthcare environments in which ESR1 testing through ctDNA can be performed. And first of all, let's say sensitivity is essential. In the first line setting, mutation frequency is often lower, especially in early resistant phases. So we require highly sensitive and validated assay to detect low allele fraction variants with sufficient confidence. For this reason, platforms such as digital droplet PCR and next generation sequencing are preferred because these offer both sensitivity and quantitative accuracy. In this particular setting, real-time PCR, in contrast, generally lacks the resolution needed and is generally not recommended for this purpose, particularly for ESR1 testing. Equally important is the standardization of the diagnostic procedures, because sample collection and processing must follow extremely strict protocols. When we use circulating free DNA preserving tubes and rapid plasma preparation to minimize contamination is an important step because it's clinically relevant. And another point is the interlaboratory standardization of the assays and the interpretation threshold that is critical to ensure reproducibility and clinical reliability, most important. And finally, I think that a clear reporting of the testing result and the interpretation guideline for clinicians are key for translating these molecular findings into therapeutic decision, particularly in a setting where early intervention can really alter the treatment trajectory. Altogether, this element, in my opinion, makes ctDNA testing not only feasible, of course, but clinically impactful in the proactive management of hormone receptor positive breast cancer in the metastatic setting. Now, Francois, I think that there are a couple of challenges that is worth discussing. For example, when to test, when to start the testing at baseline, treatment initiation, and the length of monitoring intervals, weeks, 1 month, 2 months, how this can be decided not only from the methodological point of view, but from the clinical point of view.
Yes, so that's a very important point to consider when seeking to CRNA6 and how to implement ESR1 testing in the clinic. So it's from a medical oncologist perspective, it's when to request this test. So first, we have to remind that these ESR1 mutations are mostly selected during the treatments with aromatase inhibitor. And so very few mutations could be detected prior to treatment start. So when a patient with an endocrine sensitive tumor, metastatic with metastatic spread, start a treatment, it's in my mind, I think not worthy to test for ESR1 mutation before the first line. But then later on, what we have learned with PADA1 is that after 6 months on treatment, ESR1 mutation becomes a very prevalent mechanism of resistance. So I would recommend testing not at baseline, but then starting at 6 months and then doing repeated testing throughout the first line. And then the next question that we are often asked is, what is the frequency? What is the interval between the first test and each of the subsequent tests? And so we have currently 2 trials. So one is PADA1, and we just, in PADA1, we just said that we would test every 2 months, which was quite intensive. And in CRNA6, it was a bit more relaxed, 2 to 3 months, the interval between 2 testing. So what is important, I think, is to remind that none of these 2 trials have been designed to establish what is the best testing interval. And if you look at the CRNA6 clinical trial results, there are some, let's say, reason to think that we could adopt a slightly more relaxed testing interval, which could be, something between 3, 4, or even 6 months. The idea is it is better to test even only twice a year than not to test, because it will allow the patient to benefit from the switch strategy if an ESR1 mutation is detected. So that's the take home. We wait, of course, for further data from CRNA6, but that's what the testing strategy start at 6 months and then repeat every 4 months, ideally, to intercept this ESR1 mutation. So these are, let's say, about the interval, but there are, let's say, other, issue about, clinical practice and gaps in clinical practice and challenges to implement in the routine practice ESR1 mutation testing in first line. And as we already discussed, currently, we are testing for ESR1 only once at time of progression, so late and late determination of the ESR1 status. So once the patient already experienced the disease progression, and now we have to educate our colleagues to move this ESR1 testing earlier before disease progression. And as you mentioned, Nicolas, there is also some kind of variability between testing approaches. But my feeling as a medical oncologist that, most techniques that are available around us are, let's say, have had their validity demonstrated, so we could somehow rely on them. But it's mostly when you think of a new test, you need to really check what is happening. And again, for the clinician, just to remind that the optimal interval between two tests has not been fully determined. So, which means we could probably have a slightly more relaxed testing interval. That was my, let's say, take-home message from a medical oncologist perspective. But again, Nicolas, if you want to remind your view, because it's a discussion it will be a discussion, routine discussion between medical oncologists and geneticists or pathologists who will provide the test results. So from your perspective, what are the key considerations for standardization of this test?
Good point, Francois. I think that we have to set up a framework that is able to adapt the findings from the clinical studies into the real world clinical practice. And first of all, the validated assay and the validated platforms for molecular testing are essential. We have different types of validation. There's, of course, the clinical validation that is provided by the clinical study, but also an analytical validation that can be used to adapt a testing strategy into a laboratory with a specific technological approach. So not only the validated platform, but also the certification. An assay and platform should be certified for molecular diagnostics. And in this setting, it is extremely important to use certified platforms and assay. Another point is related to the sample collection. So in my opinion, it's important to have a standardized sample collection protocol, and the sample collection, of course, starts into the clinical side of the clinical management of the patient. So is the oncological framework that should be able to put in place an infrastructure, a logistic infrastructure for sample collection and for shipment or sending to the molecular pathology or genetics laboratory to optimize the testing. And these are all quality control measures. And in my opinion, we are living in an era in which molecular diagnostics is becoming more and more important in precision oncology. Therefore, the laboratory accreditation should be mandatory for clinical decision making, as well as we do in the clinical trials. We need accredited laboratories for molecular diagnostics. But this is not enough. We also need clear guidelines for testing, the pre-analytical, analytical, and also the post-analytical phase, particularly the reporting guidelines. And this is a matter of scientific societies such as ESMO, ASCO, but also International Society of Liquid Biopsies and other societies that are fully committed for precision oncology. And another important point, in my opinion, particularly for ESR1 testing and the molecular progression, is to ensure consistent turnaround times. So the reporting of the result of the test should be provided in times that are compliant with the patient's need, and ideally before the clinical progression, so that therefore the rationale is preserved. And I don't know, Francois, what you think about the turnaround times in this specific setting from the clinical point of view? How important are they?
Yes, so here we are speaking about intercepting mutations that will lead eventually to disease progression. So it's kind of critical to have a short turnaround time. So, but having said that, so in the two trials we had, so PADA1 and SANA6, the turnaround time was of about 2 to 3 weeks. So let's say I would consider anything that is shorter than 2 to 3 weeks very acceptable. So, and I assume that this kind of turnaround time is very standard for ctDNA. So that's turnaround time is very important also when you consider the result. Of course, you don't want to get the results 3 months later, because then the patient may already have experienced the disease progression and all the symptoms and deterioration of quality of life that comes with it. So I think that if you want to recap, and that's if we have to think to the implementation steps in the clinics, so it will have to be kind of multidisciplinary, or at least combined approach between medical oncologists and pathologists and or geneticists that will be in charge of giving back the results. So it will start with kind of establishing the testing protocols, and from the medical oncologist perspective, to coordinate, of course, with the laboratory services, which could be inside our institution, but also for some other hospital outside the institute. We have to train the staff, so especially the nurses, because they will see the patient and explain also why to do this blood draw and these repeated blood draws. And we have also to develop like patient communication strategies. I think that it was very easy to communicate to the patient why we're doing it, and patients were very, appreciated the way that, we could anticipate that the drug resistance may appear, and we would like to intercept it and so on. So this is kind of easy to explain. But of course, for center which did not participate to PADA1, not to SANA6, this is kind of new. So what to tell to the patient. And we have also to create like documentation workflow. And that's very important, let's say from a practical part to implement this testing strategy in routine. And of course, there is kind of this multidisciplinary team, so which means we will have to explain. So I would say on my side, I would have to explain to medical oncologists when to order the test and what to do with the results. And on your side, Nicola, you also have a bit of I think you will have also a bit of training to do.
Yes, exactly. And actually, in the laboratory, we should also think about the multidisciplinary team that is within the laboratory. So the whole laboratory staff should be empowered and should be make aware with education about the rationale for this testing, in order to allow pathologists to oversight the testing, oversight the interpretation, and discuss proficiently with the medical oncologist, of course.
Sure. So that's very important. Also, some we have to remind the critical role of nurses, as I mentioned. Not only they are drawing blood, but they're also speaking to patient and explaining what is the reason of the blood draw. And so we actually have to explain to the nurses what we are doing. Again, many centers worldwide were not participating to this PADA1 or SANA6 trials, so it's something very new. And so we have to explain the colleagues, doctors, but also nurses and all the staff around what is happening and what is it needed to intercept this ESR1 mutation. So, Nicola, before we close the discussion, I think I just want to recap a bit very shortly what are the benefits from a clinical standpoint from this we could get from this monitoring approach, and what are the benefits for the patient, but also what are the benefits from the doctor and the whole care team. So, so what we have learned from PADA1 and what has been improved in SANA6 is that patients clearly benefit from this switch. And so these clinical benefits are coming from an earlier detection and of the resistance mechanism. So detecting earlier ESR1 mutation is key. And then this early detection is opening a window. So when the resistance mechanism has appeared and before disease progression, so now we know that we could optimize the endocrine therapy backbone, and we could optimize treatment, and that could potentially improve the patient outcome. We also reported in 2006 that there was a huge benefit in terms of quality of life for the patient. So which it really tells that rather than waiting for the disease progression and the symptoms that are coming back with the disease progression, it is better for the patient to have ESR1 mutation detected earlier. Patients are doing very fine in first line, and the idea is just by a switch of the endocrine therapy to keep the patient on the same CDK4/6 inhibitor treatment and to keep them at home or working and having an almost normal life. And that's very important because we could get this out of like the non-invasive monitoring approach, and it could help also the patient to have reduced anxiety knowing that we are monitoring the resistance at the molecular level of their cancer, and we could act even before the cancer is going back again. At the moment, I'm just saying to my patients that we'll do, say, a CT scan, or we'll change the treatment when we'll see that the tumor has increased in size. And now we could say that we could even act before the tumor has increased its size. And I think it's really meaningful for the patient. And so the switch of endocrine therapy is the first option. But of course, with the future, we'll also build other strategy and newer strategy to manage patients according to ctDNA changes during first line. I think it's very, very, very exciting perspective for the patient. And but it's not only about the patient, to be honest. There is also some benefits that the whole care team could get out of this new testing strategy. There are some benefits, let's say, from the pathologist perspective or geneticist perspective. Nicola, I'll let you comment on this.
Yes, in my opinion, a key message for pathologists and geneticists and molecular biologists is the standardization of the testing protocols. And my suggestion is to keep the first quality control parameter as the expected ESR1 frequency in that given population. So if in your practice your frequency is very low compared to what is expected, that's something, this is a warning sign, and there's something to work on. And in general, the guidelines are needed to help to improve the testing workflow in pathology. And what about for oncologists?
Yeah, so that's, let's say, as I mentioned, it's really like a very seducing strategy. The idea is, to prevent something bad that will happen to the patients. And as we could see on a daily basis, most of the time, the disease progression will come with some symptoms. And sometimes it's even worse than symptoms. It could be, symptoms that required some action or new tumor sites that need some to act on, such as epidiuritis or brain mets or stuff that really needs to be treated specifically. So the idea of preventing the disease to grow again and to extend the time on first line is very attractive, especially compared to the strategy in which you let the tumor grow again and have some symptoms and deterioration of the quality of life. And then you are trying to catch up with your treatment, which is obviously much harder than preventing the onset and the appearance of new symptoms. So that's a lot of emerging opportunities. And as I briefly mentioned, so targeting ESR1 is a very attractive option, but we expect with the near future to be able also to target other resistance mutation. And so we could expand the scope of our treatment option in patients with a rising resistance mechanism detected in the blood. So, but at the moment, I suggest to stop here our discussion, but just I want to remind like 3 points to our audience. First, the key takeaways. So first is ESR1 mutation monitoring during first-line treatment. So this is clearly a paradigm shift. So we are moving from a reactive management. So we wait for the disease to progress. Then we see whether the patient has some symptoms and we treat the symptoms and we start a new line of treatment from something that is a bit earlier, but before the symptoms are appearing, before the quality of life is deteriorating. So we are really moving to a proactive management of resistance mechanism. And ctDNA in that regard is providing a very practical, non-invasive approach. And this serial ESR1 monitoring is very important for the patient, but it also requires like a standardized protocol, multidisciplinary coordination, and clear communication strategy to the patient, but also to the entire medical and non-medical team. So having said that, so Nicola, I want to thank you again for joining me for this discussion on how to monitor ESR1 ctDNA in first line for patients treated for their endocrine receptor positive metastatic breast cancer.
Thank you.
Thank you for your attention for this activity, and we hope that this information will help you implement best practices in ESR1 mutation monitoring in your own clinical practice. Thank you again for participating in this activity.